There's a study that came out of Johns Hopkins that showed that dronabinol at dose of 5 milligrams 3 times a day reduced agitation and other behavioral complications of dementia. There's other studies I've seen in nursing home patients in Scandinavia that have severe behavioral problems and are given a tincture that is, again, similar amount of THC, 2.5 to 5 milligrams 3 times a day, reduced all kinds of negative behavioral symptoms, as well as improve the person's ability to care for themselves.
Welcome to High Five with Dr. Igor Grant, Distinguished Professor of Psychiatry and Director of the Center for Medicinal Cannabis Research at UC San Diego. Each episode will take you on a fascinating journey into the evolving world of medicinal cannabis, as Dr. Grant poses 5 thought-provoking questions to his guest, uncovering their personal journey and unique contributions to the field. Now, here's your host, Dr. Igor Grant.
Welcome, Dr. Moore. Could we begin by your saying a little bit about yourself and your interests, what you do?
Yes, thank you so much. So I'm Alison Moore. I'm here at UC San Diego, and I have been the Chief of Geriatrics, Gerontology, and Palliative Care since 2016. I also am Director of the Center for Healthy Aging and the Sam and Rose Stein Institute for Research on Aging here. It's been a terrific time being here at UC San Diego. I also am a geriatrician and a public health researcher, and my career has really been focused primarily on looking at substance use, unhealthy use in older adults, as well as diverse populations. And so I've gotten into the space of the topic of this podcast today in the last, I'd say, 5 years.
Well, great. So you're a perfect person then to talk about several issues related to cannabis in older patients. So my first question to you would be, do you have some general observations about the prevalence of cannabis use in older patients, the stated reasons for such use, and perhaps the types of products folks are using?
Sure, happy to talk about that. So like across the US and in the world, cannabis use is rising pretty dramatically in all age groups as well as older adults. More recent data indicate that when you look at National Survey of Drug Use and Health, which includes cannabis among illegal substances, that the prevalence of use in those 65 and up is about 7% as of 2023. And if you look at another survey done in similar time frame, it's called the National Poll on Healthy Aging, administered by the University of Michigan. They found that among people age 50 and older, that about 21% were using cannabis. So this was asked not in the context of other illegal drug use, which I guess I'm making the point of if prevalence rates really depend on the context in which the question is asked and how the question is asked. So I perceive the actual use of cannabis among older adults is somewhere between the 7% and the 21%. It's probably more in the high teens is where I guess it is in reality because of really the way the questions are asked and the context of the questions. It's pretty, impressive rates of use, especially since the population of older adults is, huge and only growing.
Right.
In terms of your second question about reasons for use, is that what the second? Sorry.
Yeah. What again, based on your clinical experience, why are people using cannabis?
Yeah. So this is mirrored in national data in that people are using cannabis in the medical space. So if we talk about medicinal use or medical use, it's really done to address common problems that occur with normal aging, which are problems with sleep, pain, and something that's true across the age groups, anxiety. So those are the main reasons we're seeing people report that they use cannabis for medical purposes. For recreational purposes, it's more to feel better, enjoy themselves, and that's more, I would say, those kinds of reasons we see in older adults anyway for the recreational use of cannabis.
And if I may ask, so For those that, for example, report using to help with sleep, which is a very common problem, are people generally finding it's beneficial in terms of their own experience?
So it's variable. In my practice, I can tell you I'm going to say three types of people who are using cannabis that I've come across and in my research too. So one, there's the long-term user who, either started in youth and continued using or started, then stopped and resumed use. And that group tends to use cannabis in the way that only way we used to use it back in the day is smoking, and they stick with smoking. The group that I call the flirters are those who try cannabis for a particular medical purpose. It's usually sleep or pain, although anxiety goes along with trouble with sleep and pain a lot, so it's really possible to disentangle in some cases. And they will tend to use an edible or a tincture for even topical for pain, and use products that are more commonly CBD heavy or at least THC low. That's been my experience and what we've seen in the limited literature on this topic in older adults. And then the long time users, or I'm going to say consistent users, not long time. We found in one of our studies in our primary care clinic here of older adults is that most of the people who answered our survey, it was an anonymous survey, we had more than 200 respondents. Those who were current cannabis users had started using cannabis after the age of 60. It was about 61% of them. So that was a really different different kind of data than we've seen in other surveys. And those people tend to use it, again, more consistently for problems with sleep or pain, but also treating the comorbid anxiety is my experience.
And you've touched on this. So the products people use, if they were sort of long-term users from youth, it tends to be the inhaled form. But are you saying that where people are doing medicinal use, it's more oral, various kinds of oral preparations?
Yeah, they tend to use mostly oral preparations is what we have seen in the literature and in my practice.
Yeah. Okay. Now, you've done some work on cannabis use among adults with heart disease and diabetes, right? What can you tell us about that?
So it's really honestly been led by my colleague, Ben Hahn. He has been doing a lot of work using the National Survey of Drug Use and Health. And he found that in general, that people who use cannabis in late life often have comorbid medical conditions. And we don't know yet if that's because they have comorbid medical conditions, they're using cannabis, or whether the use of cannabis that they've been using it a long time has led to these comorbid medical conditions. But the two are definitely linked, where we see people who report using cannabis in a variety of forms also report increased prevalence or presence of diabetes, heart disease, and other comorbid conditions.
And just for those who are not medical audience listeners, comorbid, you mean things that coexist together?
Or multiple other medical conditions they're also using, they have other medical conditions and they're using cannabis.
So are you saying the question is, are these folks with, say, heart disease and diabetes, is there something about their condition? For example, diabetes can be accompanied by neuropathic pain, right? Certain kinds of chronic pain. Are they using it for that? Or is it the case that somehow the cannabis use is causing metabolic changes that promotes?
I think that's one of the many areas in which we have inadequate evidence to really have a answer. I read a little bit more today about the diabetes and cannabis connection. And so it's very unclear if cannabis has a direct effect on the, insulin sensitivity or glucose levels. But what I've read really says it's more if you're high after using a THC containing product, then you may be less aware if you're experiencing hypoglycemia, for example.
I see.
Or if you're, so that's a danger. Or you may be less good about eating a diet that's, better for one who has diabetes. So not a lot of sugar, not a lot of simple carbohydrates when you're in this state of, as we used to call it now as in college, the munchies. So that I think is where we are now with the evidence in this space, as far as I'm aware.
More likely to eat your Cheetos when you shouldn't? Is that what you're saying?
Yeah, high. Yeah.
Okay, so it's an evolving question, chicken and egg question here. And as with many things in medicine, it's often both, right? That
Yes.
some things are promoting something, but maybe it's also being used because there's something
Yeah,
else is there. Uh,
yes.
right.
And that to me, honestly, if I may interject, is one of the fascinating things about this topic. It's so complicated. You know this, of course, way better than I do, Igor, but it's such a complicated topic, and people sort of view it as one thing, but it is so not one thing. Prior to my career in cannabis, I really focused on alcohol, and that was complicated enough, but cannabis is a whole nother level of complication. I really try to tell people like it is not just a thing, it is so many things. It's the THC CBD content, it's the form in which you're using, the context in which you're using, and we can't really say if it's both good and bad. That I'm clear on. But just how good and how bad, how good especially, we just have inadequate data.
So, as a total non sequitur, Alison, tell me it's okay that I have my glass of wine. Everybody's now saying, "Oh,
I know. Haven't
no amount
Igor?
is good for
Yeah.
you."
Yeah, over our careers, you're having you said like alcohol's good, alcohol's bad, opioids are good, opioids are bad. It's just this all the time. So I'm just like, yes, a glass of wine I think is fine, given all the cohort data we and even the short-term randomized controlled data we have show that a glass of any form of alcohol, not a glass, a dose, a standard dose, one standard dose of alcohol a day is generally, okay, if not having some cardiovascular benefit, which I know I might be, faulted for saying. It certainly can increase risk for atrial fibrillation in people who are at risk for it, which is aging people. But in general, it just has so much data showing its benefit for lipids and insulin sensitivity and diabetes. Anyway, so I'm a believer that yes, one dose or one standard drink a day is fine for most people.
So I can keep raising my high density lipoproteins with a glass of
Yes.
wine. Okay, thank you for that reassurance. Okay, moving on. Now, can we talk about, older adults are at risk for developing dementing disorders, and some of those have significant behavioral problems, which pose challenges for family, certainly for care providers as well. We know that some drugs to control severe behavioral problems like antipsychotics either don't work well with older people or are plagued with significant side effects, which limits their use. Is there any thought that cannabinoids might have utility in this space? People with dementia and severe behavioral problems.
Yes, we're accumulating more evidence that given again the right amount of cannabis THC content, given the right way, for the right person is helpful. There's a study that came out of Johns Hopkins that showed that dronabinol at dose of 5 milligrams 3 times a day reduced agitation and other behavioral complications of dementia. There's other studies I've seen in nursing home patients in Scandinavia that have severe behavioral problems and are given a tincture that is again similar amount of THC, 2.5 to 5 milligrams 3 times a day, reduced all kinds of negative behavioral symptoms, as well as improved the person's ability to care for themselves and improved the caregivers also. So it had, I'm going to say, dramatic benefits in this population and is definitely worthy of more study, but is very promising. We're currently working on a project now where we're interviewing caregivers of people with dementia who personally do use cannabis. And we hope to find out with this a little more granular um, data on, why they're using it, how do they find it for themselves, as well as if they use it for their caregivee with dementia.
Right. Just again for folks that are listening, the dronabinol is a chemically produced THC, basically, which is actually approved for certain kinds of indications, right? I don't know if you heard me okay.
I did.
Yeah, thanks. So, all right. So possibly is a role here. And again, I'm sure then clinicians would be struggling with risk benefit because THC, of course, can cause memory problems, at least acutely. And so it's balancing the behavioral benefits versus maybe some cognitive impairment that could be induced by the THC. Does that seem right?
Yeah, that's right. And one other point I'd like to make, if I may, is that and maybe we'll get into this, but it really does depend on how you're using cannabis and in what form. The risk ones needs to be worried about, or the the factors that need to be considered. So, for example, if you're, everyone thinks, the gummies are safer than the inhalation of, cannabinoids, including primarily THC, but that is not necessarily true. And it's because with the gummies, we've seen that because they have a longer and more variable onset of action, people have taken too many of them. So the window of onset of action for oral, like a gummy or a brownie or something, is between 30 minutes and 2 hours. And so we've seen that people, and they taste good, right? So people will take one and then they're like waiting their 15, 20 minutes, like nothing's happening. I'm going to take another, and then maybe not take another, and then they end up with an overdose situation where they're experiencing psychosis or excessive sedation, or they're fallen, and then they may end up in the emergency department. And we've certainly seen increased emergency department visits over time in older adults that are related to cannabis. So
Hmm.
that's one of the risks with the inhaled versions being or smoking. It hits you much quicker, and again, dosing matters, but it hits you much quicker. So you're going to know what it's doing to you quickly, as opposed to hanging out waiting for something to happen. It doesn't, you then take more and more and overdose.
Yeah. Yeah. So that's really important that what we call the pharmacokinetics, the time course in which your body handles a medicine and how high your blood levels are when it's cleared and all of that is very different from the inhaled versus oral forms. Yeah. So somebody really has to ultimately see how their body tolerates these things and what the correct dose is, and that may involve some trial and error, right?
Which
Yeah.
is scary because mostly they're doing it on their own, right? But one of the things we know about is that people are, at least older adults for sure, are getting information mostly not from their healthcare providers on this. So that's also can be concerning. My experience has been they get it from their kids who purchase it and, say, Dad, Mom, try this. And, or they're going straight to a dispensary to get the bud tender to tell them what they should be using and how. So that's, scary. Or they're worse, going to an unlicensed dispensary where more risk for not even the packaging, not even being accurate about what you're taking, or Delta 8 is out there. And that's also, we know risk. It's, not Delta 9, but Delta 8, but still has big, uh, same effects as Delta 9, maybe a little less prominent, but trouble. And so these are the concerns we have. And then, yeah, these are some of the concerns we have.
Yeah, just speaking a little bit more, I mean, we're in California, which is a marijuana legal state and does have a reasonably robust regime to regulate dispensaries, which are required to post what's in their products. Now, it may not always be exactly correct what's posted, but at least it's not a total black box. So I think consumers can be at least somewhat properly informed what's in there. You mentioned Delta 8 THC, and that has an effect sort of like THC light, as you said. But one problem there may be also not just the THC itself, the Delta 8 THC, but how it was produced. And so if it was produced using chemicals that are then contaminants in this concoction, they themselves can have bad effects beyond the THC. So I think you would agree, I would caution anybody from getting their marijuana from other than a licensed dispensary, at least in the states where this is legal.
Yes, thank you. Thanks for that.
There's more, at least somewhat more quality control there. Yeah. Yeah, don't get it from your kids because they may be used to 30% THC, and that will really knock an old person out.
Yeah. Although I haven't seen that so much. I haven't seen them overdose their parents, thankfully.
Yeah. It's more actually very young children that inadvertently, they think it's candy and, they may take 100 milligrams of a cannabinoid by mistake. And that definitely, it's not going to kill them, but it's going to definitely cause them to have a terrible experience. Yeah. Okay. Well, good. Now, another area that is important, it seems clinically, is to get accurate histories from people about whether they use cannabis or marijuana. Do you think there is reluctance or, do people hold back on this information? And if so, why? Do you have any experience in that area?
Yeah, I do. So this is again, another one of those fascinating and complicated topics related to cannabis and health and primary, I'm going to say the healthcare provider. So I would say one of the challenges I've thought about, it's the same for alcohol. Substances are typically part of the social history. And so we don't really ask about them consistently. And also I've tried myself, it's difficult, if not impossible, to put cannabis, any dose of cannabis or use or form of cannabis, like in the medical record. And so as you have, as a primary care provider, you always see that list of meds that the patient has. And many times over the counter things are included like acetaminophen. But I've never seen cannabis or even, alcohol, what they're drinking as part of that. So it makes it harder for your average primary care physician because we're not used to looking at it, and it's not in a location that's easily accessible. So when I go in, if I've talked to my patient about cannabis and they told me the dosing or I've asked them what you're taking and I put it there, I have to like sort of peruse my note to find that information. So it's a little harder to find. Also, another complication is that people who use over the counter non-prescribed medications, they barely know the doses of what they're taking, but I can at least look it up and see and confirm. But if you talk about something like cannabis, they often have just no idea. So I literally have to say, bring in what you're taking or put it in, my patient portal. Tell me what you're taking. What's the dose? Because without that, you're kind of, in trouble all around. You just don't know what you're doing. In terms of even finding out what the patient's using, again, it's not part of our typical training to say, are you using, we now have a standard alcohol screening thing, I'd say in most medical contexts, your nurse or, does ask those questions to find out and shared with you. But cannabis and other substances, it's not really asked. So one, you have to have the wherewithal to ask, or the standard procedure of asking. And then as a physician, you also need to be able to handle what answer you will get. So it's not only not knowing how to ask, having the stigma on the patient part of not disclosing to the doctor what it is, because again, the patients who are, especially older people growing up, it was illegal all the way around. So it's still the stigma of using a drug that is illegal still in, many states, even if it's been legal here for a long time. And so I think that gets them to be shy about disclosing. It's also a psychoactive substance, which I think everyone knows. And we know doctors aren't thrilled with you, psychoactive substances, as they should be not thrilled with it. And so I think that's another reason for failure to disclose. But part of it, as I was alluding to earlier, is it's hard to get data on something you don't really know enough about. And we know this from our interviews with physicians we've done and others have done, is that if they don't know what to do about it, or even the risks exactly, or knowing the dosing and what, it makes it very hard to want to go there. You feel like it's kind of something that's they're doing outside of the medical context, similar for alcohol use, but less so. And sort of that isn't my territory. That's what I'm going to say about that. It's one thing we really want to do is get cannabis education part of regular medical education. There is no courses on it at UCSD that I'm aware of in medical or pharmacy school. I think there's one elective. So if we don't get the information as part of our regular training, we're getting it like everyone else does, kind of, looking forward as we can, hopefully getting some presentations, but it needs to be part of our medical education.
Right. Just on the issue of patients feeling comfortable discussing this, do you think also there could be reluctance in terms of, I don't know, insurance coverage, other kinds of risks that patients may feel, or even employment if the information is then disclosed somewhere else? I mean, I know we always say it's confidential, but we know that's not really
Yeah.
true in many cases. Do you think any of that plays in, or is that?
Yeah, that's a good point. I would say I haven't had experience with insurance being a challenge, but employment's a real risk, like you said, Igor. And as we know that if you're drug tested, it stays in your system forever. So you're in trouble if you're getting drug testing and you use cannabis, a while ago, even, for one gummy or something. I think that could be part of it. Again, in my practice, I don't see too many people who are currently employed, but I'd say that's a reasonable concern that they might have. And we try to, again, protect people in these situations by saying, I guess, I should know if I wouldn't document or if I would be able to withhold medical records. I don't think you can. So you're right. That's a tricky point.
Okay. Now, you had mentioned physician education. That's actually a final area that I'd like to chat with you about is based on your experience, what should be done first on the physician side to inform physicians about cannabis, particularly medicinal cannabis. And then the other side would be, what would your advice be to patients who might be considering use or are actually using? So let's start with physicians because you introduced that topic,
So how, what is,
needing to educate. What is it that your colleagues ought to know about medicinal cannabis in the elderly, for example?
right? They should know some basics, I would say, about one, how to ask about it in a way that's not judgmental, that will not put off the individual. We're pretty good at that, but just saying to use cannabis for medical reasons or even recreational reasons, or you could start it off by many people use cannabis. Increasingly, we know this in older age groups to treat a variety of symptoms, or if they've used it long term. What's been your experience with that? So making it sort of a more open-ended question. And then the physicians and other healthcare providers, pharmacists as well, dentists, others, need to understand sort of what are the forms of cannabis and how they, affect your body, right? So something about how quickly they're going to feel, what doses of cannabis are typically in a puff of a THC containing product, if one can know that, and uh, or how much is in a gummy, or are there recommendations for dosing given various types of forms? So inhalation, ingestion, topical. And one organization that's done well with this, I wrote it down because I forget the name often, is the Canadian Center for Substance Use and Addiction, I guess. They have a wonderful infographic on dosing, form of use, how quickly it's going to affect the older adult, and recommended, if there is any recommended dosing of that. So, we typically say inhalation's no good, don't do it. It only can hurt your lungs, and a lot of data suggesting with proving that. Suggestion, be careful, really aim to know how much THC and CBD are in the thing you're ingesting. Again, it's most commonly gummies I've seen in my experience, or even a tincture. So aim for no more than 2.5 THC, similar amount of CBD. When you're starting off, you might have to go up to 5. 10's probably too much for most older people. And then for topical, there's really not a whole lot of risk that I've ever witnessed in that. So the topical products, that may or may not work. I think the jury's really out on that, although they're certainly sold a lot in, at least in California, in our drugstores, in our grocery stores, in our pet stores. I mean, it's all over the place. So knowing those basics, I think, are important. Also being able to advise your patients about how to find, if you're going for a THC product, how to find a dispensary that is regulated. We can do that pretty easily in California. Knowing something about the potential negative health consequences of cannabis, even sort of the GI side effects, which you can get nausea, vomiting. Some people really get that even with low dose. Certainly the sedation, the fall risk, coordination, being aware of that, no driving after using cannabis within 2 hours, and also knowing to be, I'm going to say, circumspect about the potential health benefits. One of the things about Igor is that we were hoping that cannabis might actually reduce the amount of drugs that people take. We think are probably less safe if the cannabis is being used more safe way, and those are the opioids and other, sedating types of drugs. And what we saw in our small amount of research so far is that people use cannabis more as to augment the effect of the opioid or the sedative they were taking for anxiety or pain, and weren't really reducing the amount of the other medication they were taking. I know there's a wider literature on this I'm not well versed in, but that was a hope. So being aware, as you said, taking a good history, knowing what other psychoactive substances your patient is taking, whether it's alcohol, whether it's a sleeper, over the counter, or prescription, is really important to know. Knowing if they have a history of cannabis use disorder, which again is a big risk even for older adults. I mean, over the lifetime, fewer people have meet DSM criteria or the standard psychiatric criteria for substance use disorder, as we call it now, but we still have them. In one of our studies, small group of people who are like sort of long-term cannabis users, a third of them met criteria for cannabis use disorder. And so if you're seeing your patient increase the amount that they're using to achieve the same effect, or if you're seeing them spend more money than they should on the product or more time getting its standard criteria we use for substance use disorder, you have to be aware of that even in older adults. We know addiction is and substance use disorder is highly underrecognized in older people, but they still have it, and it is a risk even for new users that can happen. But certainly for people that have a history of a substance use disorder, initiating cannabis is tricky business.
When we talk about disorder, just to clarify for our listeners, we're talking about a type of use that is habitual, maybe increasing. There's a preoccupation. It may have negative effects on your health or social functioning. Is that what you mean by disorder?
Exactly.
Yeah.
Thank you for clarifying that.
Okay. Just so we know. Now, just coming back to something we talked about earlier, inhalational oral, we've said that one advantage to the inhalational route is that you're able to, shall we say, titrate the dose much more carefully. That is, the onset of effect is almost immediate, and then the offset is faster also. So you kind of have more control over it. Why not? Why would we argue against such use? Because presumably someone who's using it medically is not using it to a point of damaging their lungs. And even there, the risks for cancer are unclear, even with very heavy long-term users. So other than the fact you're blowing smoke into the environment, maybe, which may not be nice for others, is there a reason we should counsel against it?
That's a good point. Or I would say that, I wouldn't recommend that people use you know, the leaf or flower, the actual plant in an inhalation way, like a joint. It's one of the ways we call it. But I think a vape pen, if it was using a electronic vaporizer or vape pen, might be a reasonable way to go. And I know in countries like Israel, they've definitely been using this and studying it, particularly in people with cancer and pain related to cancer. And as you say, having a more reliable and defined period that the cannabis is going to affect you is helpful and may even be safer, as long as you know how long that it's going to last, no matter what you're taking. So I agree that in that situation, it could be a good way to use the cannabis to help with particular condition.
But that's not to say vape pens are perfectly safe either, because their use may involve introducing other kinds of chemicals into the vapor, they themselves have damaging effect, products of high heat and so forth. But anyway, I guess nothing is perfectly safe. It's always a balance. So anything else that you might say in terms of educating both the patient and the providers? We've covered quite a lot here, but anything else that you'd want to say by way of wrap up on that?
Yeah, I guess for the patients, I'd say if you're interested in using a cannabis product, really try to educate yourself about it in advance, and you can do that in a variety of ways. Again, this Canadian resource is amazing. The Canadian Center on Substance Use and Addiction has a Cannabis Use in Older Adults Guide that was issued in 2020. It gives in infographic form, so easy to see and read and ingest, or so to speak, form of education on this topic. And then, of course, you can learn from anyone you can learn from. So that's reliable. So some cannabis dispensaries have excellent information on how to use cannabis in a safe way, and certain individuals who work at these dispensaries can too. Ideally, your healthcare provider can also provide you some education on this so that you really can have the best chance of using cannabis in a way that I would say is responsible and increases its safety as well as potential efficacy for whatever you're choosing to use it for. And then in terms of the healthcare providers, I would say similar advice. Learn what you can. This infographic from the Canadian Center on Substance Use and Addiction was super helpful to me in my learning about cannabis in older adults. There's a ton of literature out here now. It's a really exploding area of research. So learning what you can in that context. Also pushing for education so that you can get it all along your career. Education on use of this substance has been used for millennia and now is, being considered for broad FDA approval. So it's here to stay. And so I would say it's really your responsibility as a healthcare provider to learn more about it. And again, I hope we can institute that education as part of what we do for our healthcare professionals as they begin their training and throughout.
Good. Well, I think that's a good wrap up. We've been speaking with Professor Alison Moore, who is the chief of the Division of Geriatrics, Gerontology, and Palliative Care at the University of California, San Diego. Thank you so much, Dr. Moore.
It was my pleasure. Thank you, Dr. Grant, for having me.
If you like this podcast, please subscribe so you don't miss future episodes. For more information on the Center for Medicinal Cannabis Research at UC San Diego, please find us on social media at CMCR_UCSD on Twitter or X, Instagram, and other social media platforms, or visit our website at cmcr.ucsd.edu. Thanks for listening.